Thank you and good afternoon. I'm Sharon Mulvagh from Halifax, Nova Scotia, and this afternoon we're going to be talking about echo contrast in the critical care setting. I do have several conflict of interest to disclose. I do have a grant recently awarded from the Canadian Cardiovascular Society. I'm an advisory board member for Lantheus Medical Imaging and a steering committee member for Novo Nordisk SOUL trial. And I will be discussing off-label uses of ultrasound enhancing agents for myocardial perfusion as recommended by ASC guidelines. The learning objectives that I'd like to cover with you over the next very quick 20 minutes is to understand what ultrasound enhancing or contrast agents are and how to administer them, to know indications for the use of ultrasound enhancing agents in the critical care and emergency department environments, to describe the clinical impact of their use, and to recognize the incremental value of myocardial contrast echo perfusion imaging, and to become aware of new and future relevant applications of echo contrast. What are contrast echo agents? Or, as we're calling them as well, ultrasound enhancing agents. And I'd just like to make a point about why we are using the terminology ultrasound enhancing agents. It's to reduce the confusion really in communications with our patients. When patients hear the word contrast, they often think of radiographic dye that could impact on their kidneys. And so it's important for them to understand that ultrasound contrast agents are different, and the terminology, therefore, ultrasound enhancing agents is what we've chosen to use. Ultrasound enhancing agents are stabilized gas microspheres or microbubbles, which are sized to pass through the smallest capillaries. Microbubbles are composed primarily of air, stabilized by a small amount of inert gas, and enclosed by shell. The components of ultrasound contrast agents and desirable characteristics are listed here, and the different companies have different components in their agents. The unique thing about microbubbles in comparison to most other imaging contrast agents is that they are pure intravascular tracers and they do not extravasate outside the microcirculation. Indeed, validation studies using radio-labeled microspheres show excellent correlation with microbubbles for the quantitative assessment of myocardial blood flow, as shown here. There are currently 3 approved ultrasound enhancing agents by Health Canada as well as the FDA, but here in Canada only 2 are marketed commercially at the present time, including Definity and Soniview, which is also known as Lumazon in the US and in Europe. It is known also as Soniview. The approved indications are for left ventricular opacification and endocardial border delineation. However, they are very useful for the assessment of myocardial perfusion as well, and we will discuss that, but it is recognized to be off-label. What are the guidelines for usage of echo contrast, and particularly as it relates to the critical care setting? Specific reference to the use of contrast echo in emergency and critical care settings was first published in 2013 in the recommendations from the European Association of Cardiovascular Imaging. And they specifically recommended contrast echo for the evaluation of global and regional systolic function and post-infarction complications, including left ventricular pseudoaneurysm and thrombus. And as well, contrast echo has a role to play in the assessment of aortic dissection. They noted that there were no reports of mortality increase in critically ill patients upon contrast administration. The ASC Guidelines Update document published in 2018 also provided specific guidance for the use of ultrasound enhancing agents in critical care and emergency settings. And these recommendations are summarized here, specifically addressing the situation of non-diagnostic electrocardiograms and the incremental value for both left ventricular opacification for assessment of wall motion abnormalities and for perfusion, as well as evaluation of the known complications of myocardial infarctions, such as left ventricular function depression with regionality, thrombi, microvascular flow abnormalities, reperfusion assessments, and complications post-MI. And of course, in the current COVID era, Our ED and critical care colleagues are experiencing unique and overwhelming competing needs for accurate, rapid information with minimal contact and sparing of personal protective equipment. Both the ASE and CSE have produced guidance statements on performance of echo in the COVID environment, and ultrasound enhancing agents are mentioned as having particular potential benefit to improve accuracy and speed of imaging, as noted here. So with that brief introduction, let's address what are the applications for use in the ED and critical care environments. The obvious one is to improve the feasibility of transthoracic echo in a generally hostile environment of technically challenging echoes due to the patient positioning and comorbidities that we have discussed. There's clear benefit in changing a non-diagnostic study to a diagnostic one, avoiding downstream testing, additional unnecessary downstream testing, transportation, and exposures. What appeared to be possibly very poor LV function in this case is actually hyperdynamic, as you can see when contrast is added. What you don't see certainly can hurt you. From beyond the initial recommendation of greater than or equal to 2 contiguous LV segments not adequately seen, the most recent guidelines state that if the indication is to improve the cardiac structure or function assessment, then contrast can be used without counting up the number of segments. Beyond general left ventricular function assessment, regional wall motion abnormality assessment is critical in evaluation of a patient with symptoms suggestive of an ischemic syndrome. The differential of global from regional wall motion abnormalities is critical, as is the knowledge of the association of the typical myocardial perfusion distribution of epicardial coronary arteries. Here is an example of what appears to be normal regional wall motion on an unenhanced echo on the left, but due to foreshortening, this apical long axis view is not optimal, and with enhancement, now a true apical long axis view can be obtained, and we can see clearly that there is an inferolateral regional wall motion abnormality as demonstrated in the very low mechanical index image on the right-hand side. There's also relative thinning of the myocardium in that area. Here is an example of the opposite situation where there appears to be a regional wall motion abnormality at the apex. And note that in the upper right-hand corner that the patient's electrocardiogram showed deep T-wave inversions. However, when contrast is administered, we can see that indeed there is no regional wall motion abnormality at the apex, but rather there is left ventricular apical hypertrophy, which is often a masquerader for a wall motion abnormality. I've seen this happen several times, and many colleagues similarly. So if the story isn't fitting and you suspect that there is apical hypertrophy, it is essential to use contrast to make this diagnosis. Complications of acute cardiac ischemia are often seen in the critical care setting. Here is a patient with an obvious apical wall motion abnormality and findings certainly consistent with an apical thrombus. However, with contrast enhancement, the extent of the thrombus and actually the mobility along the edge of it can be readily seen, and the infarcted area is more clearly identified. Demonstrated here is the value of ultrasound enhancing agents to confirm a pseudoaneurysm. Here on the left, you can see that there is an echolucent structure adjacent to the left ventricular apex. On the right, with the administration of contrast, this clearly defines a left ventricular apical pseudoaneurysm with a narrow neck and a wide body of the aneurysm, classic for this diagnosis. Beyond the use of ultrasound enhancing agents for LV opacification, myocardial perfusion can be quite helpful, particularly in managing acute ischemic syndrome patients. This demonstrates the use of LV opacification to show a wall motion abnormality in the anteroseptal to apical region seen here in this apical long axis view, along with an perfusion demonstration, which is slightly delayed but present despite the area of reduced function evidenced by the wall motion abnormality. So this would be consistent with a wall motion or function perfusion mismatch. And in this case, this was a lady who'd had a respiratory arrest due to an anaphylactic reaction, and she suffered a non-STEMI with elevation of troponins, and she also had acute kidney injury with an elevation of her creatinine. So the question was she most likely had a type 2 MI and likely related to stress cardiomyopathy. Um, there was reluctance to take her to the cath lab because of her elevation in creatinine. So we didn't. And a month later, she came back and she had normal LV function. It had completely recovered, consistent with the retrospective diagnosis of Takotsubo's. And thus, the important thing is that the perfusion information, which was slightly delayed but preserved despite the area of regional wall motion abnormality, was very helpful in her management. Now, I'd like you to contrast the last case to this case. This is a 61-year-old female who was a couple of days post-op renal transplant and on a routine electrocardiogram before dismissal was read as having STEMI. She had significant ST segment elevations in the anterior precordial leads. And in her perfusion echocardiogram, as you can see here on the left, after the high mechanical index flash there it was, you see very, very black area where the wall motion extends from the proximal anteroseptum. Again, this is a apical long axis view, and extending all the way around the apex and into the inferolateral wall. Now, the point is that there's no evidence of microbubbles in this akinetic segment. So one would think that this is most consistent with infarction in this area. And indeed, she did go to the cath lab. She was found to have a subtotal proximal LAD stenosis, and this was stented. And when she returned a month later for a follow-up echo, she unfortunately has a persistent wall motion abnormality that you can see here from the mid to apical region. So you could predict in this case, because of the absence of perfusion and the distribution of the wall motion abnormality, that this function was not going to recover, and indeed it didn't. Because ultrasound enhancing agents can be very helpful in differentiating intracardiac masses at the bedside in a critical care or ED environment. As shown on the left, a thrombus has no perfusion and remains black or echolucent, while a tumor is perfused and will demonstrate microbubbles within. In general, a malignant tumor is more highly perfused, as seen here on the far right in the right ventricle, filling nearly the entire right ventricular apex. There is a mass which is very highly perfused. In the center is another mass, and this has a less degree of perfusion than seen in the metastatic tumor, and slightly less than what is seen in the myocardium. This appearance is consistent with a myxoma. Aortic dissection is another condition seen not infrequently in the ED, for which the diagnosis is critically important and sometimes easy to miss. Contrast echo can readily demonstrate true and false lumina, and sometimes the entry tear, as seen here in the right panel. In a single-center study of over 100 patients, the sensitivity and specificity of enhanced transthoracic echo were similar to conventional transesophageal echo in detecting dissection of the ascending aorta, on the order of 93 versus 96% and 98 versus 96% respectively, as well as in the arch. What about using contrast echo in the assessment of patients with assist devices or circulatory support? We looked at our Mayo experience several years ago when Dr. Noel Fine was an echo heart failure advanced fellow with us and found that the use of contrast appeared safe and useful. Here you can see several case examples with non-contrast images on the left panel and after contrast on the right in the still frames. On the right-hand side, you can see a video which demonstrates the presence of a thrombus adjacent to the inflow cannula at the left ventricular apex. Overall, ventricular function assessments were improved with the improved image quality with contrast, and significant management impacts were observed. We also looked at our Mayo experience several years ago regarding ECMO, and although contrast was used infrequently, it was helpful and safe, with the proviso that a perfusionist must be available at the time of the study in the event that the air detector alarms, which can occur due to the presence of the microbubbles. The videos show an example study of a contrast benefit in a young woman on VA ECMO for complications of sepsis. A mass was seen on the non-contrast echo and was clarified to be extracardiac, consistent with a mediastinal coagulum causing external cardiac compression. So how do you optimally perform contrast echo? Ultrasound machine settings to optimize contrast are essential to understand. Most often, we prefer very low mechanical index imaging for left ventricular opacification because this preserves the contrast agent, destroying the least amount and giving the best images. It's important to understand that if the endocardial border is not distinctly seen as very low mechanical index imaging progresses, the use of transient high mechanical impulses will restore the sharp demarcation of the endocardial border, while also giving you perfusion information. Shown here are the comparisons between tissue harmonic unenhanced imaging on the left, which is always at high MI. In the center is low mechanical imaging with contrast, with a marginally beneficial contrast effect. And at the far right is the optimal strategy of very low mechanical index imaging. And for those who are astute, there is indeed a small but mobile thrombus at the apex of the left ventricle, which is only seen with very low mechanical index imaging. To understand how best to optimize our ultrasound machine settings, it helps that we understand how microbubbles interact with ultrasound. They expand and contract as they are resonating in an ultrasonic field, and this is termed nonlinear resonance. This microbubble was imaged with a special camera at 25 million frames per second, and you can see the expansion and collapsing of the microbubble. Shown in this schematic is the effect of a microbubble that is exposed to increasing acoustic power or mechanical index, the MI. At low MI, at the left of the diagram, only linear backscatter is reflected from the microbubble. But as the MI is increased, the microbubble begins to resonate, creating nonlinear resonance or harmonics. And with a greater increase in the mechanical index, acoustic cavitation or microbubble disruption occurs, destroying the microbubbles. A large signal is released at the time of this cavitation. The nonlinear resonance permits enhanced ability to detect microbubbles compared to the surrounding tissue, and thus is the preferred strategy for both left ventricular opacification and perfusion imaging. There is ample literature supporting perfusion using ultrasound enhancing agents, and although no commercially available ultrasound enhancing agent as yet has a specific indication for perfusion, it has been recommended in the AAC guidelines because of this substantial literature supporting. Indeed, the emergency room is a specific location that has been studied with respect to the incremental value of perfusion in patients presenting with chest pain, and a non-diagnostic ECG in particular. Assessment of regional wall motion abnormalities in combination with perfusion was found to be the most robust in predicting outcomes, with patients that had a normal wall motion and normal perfusion having the best outcomes. What is the clinical impact of contrast echo use, particularly in critical care areas? In an interesting study from Baylor that's evaluated not only the impact of ultrasound enhancing agents on image quality, which you can see here certainly was improved with the addition of contrast, but they also evaluated the impact on management outcomes. And they found that the most significant effect was in the ICU settings, with over half of patients in the surgical intensive care units and a third of patients in the medical intensive care units having changes in management associated with the test information that was received that included the ultrasound enhancing agent results versus those that didn't. Moreover, there was actually a cost savings by avoiding unnecessary downstream subsequent costs in these patients that could have a definitive diagnosis based upon the results of the contrast echo. What about safety? The safety profile of contrast agents has been extensively studied, although a black box, due to a retrospectively unsubstantiated safety signal associated with some post-marketing pseudo complications, was placed in 2007 and it still remains. The only current contraindications to ultrasound enhancing administration includes a known allergy or sensitivity to the product. Indeed, a citizen's petition has been submitted to the FDA almost 2 years ago now to rescind the black box, and response is yet pending. Warnings remain regarding use in critically ill as a caution. It is important to note, however, that rare, that means on the order of less than 1 in 10,000, hypersensitivity reactions can occur, and they're thought to be related to a complement activation related pseudoanaphylaxis or a type 1 type hypersensitivity. For this reason, ultrasound enhancing agents should only be utilized in settings where resuscitative equipment is readily available. I'd like to close with just a few words about some exciting work that is being done by colleagues in the area of sonothrombolysis, because this is very relevant to the emergency department and critical care. This groundbreaking work is being done by Dr. Wilson Matthias and his group in Brazil in collaboration with Tom Porter in Omaha, Nebraska. And they've been using intermittent high MI ultrasound treatments, which are delivered with commercially available ultrasound transducers and commercially available contrast agents. They're given before PCI and for 30 minutes after PCI. And they have been able to improve angiographic recanalization and microvascular perfusion in these patients with acute STEMIs. And as well, they've been able to visualize the infarct risk and reperfusion areas, which have improved. So there is a utilization of contrast echo as both a diagnostic and a therapeutic tool with this technique. But moreover, just this last month in Circulation Imaging, they published additional 6-month outcomes data, which showed that the observed improvements in the microvascular flow resulted in better myocardial mechanics and reduced left ventricular remodeling, as evidenced by improvements in both LVEF and global longitudinal strain. So protocols are also ongoing in Europe, which are exploring the administration of this sonothrombolysis technique even before patients get to the emergency room, in other words, in the ambulance. So this is something to watch out for, and certainly is proving to be looking like a promising technique. So the take-home messages include the following regarding ultrasound enhancing contrast agents for critical care and the emergency department. They are useful, safe, and cost-effective. They provide improved feasibility, diagnostic accuracy, and prognostic value. They use very low MI with a brief high mechanical index flash. This type of imaging is best to be able to evaluate both left ventricular opacification and perfusion. The future is very exciting with the therapeutic use of contrast ultrasound in the emergency room or even before patients arrive in the emergency room, and this is termed sonothrombolysis. It's important also, of course, in the critical care and ED settings to recognize that contrast-enhanced ultrasound also has non-cardiac applications of relevance to the intensivist and the emergency doctor. So I thank you for your attention, and I look forward to your questions. Thank you.